Hello, this is Denise. I am an attending gynae pathologist at Hacettepe University. Today I'm going to present you a case of a vaginal mass. A 72-year-old patient was admitted to an external clinic having a complaint of postmenopausal bleeding, and she had a palpable vaginal mass, and she underwent a biopsy of the lateral vaginal wall. In this center, the pathology report is concluded as a papillary neoplasm consistent with borderline Mullerian papilloma. And the blocks, the formalin-fixed and paraffin-embedded blocks, was sent for second opinion to our center. So at very low power, what we see, a mushroom-like proliferation, and presumably this part of this proliferation is cauterized area, and it has lots of hyalinized areas and some fibrovascular cords. Let's go higher power. At higher power, we can appreciate lots of papillae. They look sort of hierarchical, but I think they're not hierarchical because some of which are very hyalinized, and you can see congested vessels over there. Closer inspection, there are not significant atypia of the cells. There's no evidence of atypia, and there are some hyalinized areas and some tubules like that. There we go, some tubules, and moreover, there are some tubules contained with colloid-like proteinose structures, proteinose material. After this, for this papillary lesion, some bunch of the piles of immunostains has been ordered. As you expect to see, it is cytokeratin positive, and it is PAX8 positive, GATA3 positive, but it's not very it's not very intense. It is like that, but it's positive. Some areas are better. These areas are better. It's like patchy, maybe more than patchy positivity in the cells. So the other immunostains, the tumor is ER negative, PR negative, which is a very important finding I will discuss later. It is AMACR negative, NAPSINA negative, and it is TTF1 negative, D240 for mesothelial proliferations, and again, calredinin is negative, CD10 is negative, W21 is negative. So when we're talking about the vaginal mass, when we're talking about the vaginal mass, the metastases should be the first differential diagnosis. Patients should be evaluated for metastasis. But this patient has no evidence of this patient has no history of cancer. So metastasis should be the first consideration. And in differential diagnosis of the vaginal papillary lesions, in fact, it should be always considered in anything related to vagina. So metastasis serous carcinoma is positive. However, it is P53 and W21 negative. P53 is in a wild type manner. If I can find, I will show you P53 stain, but it's wild type. And mesothelial proliferation may also be possible, but is calredinin negative. Cervical adenocarcinoma may be possible. Sometimes they make papillary proliferations. But P16 is negative, and in clinical examination, cervix appearing normal. Again, for mesothelial proliferations, W21 is negative, PAX8 is positive. So it is not consistent for mesothelial proliferations. The skin adnexal tumor, the involvement of skin adnexal tumor of the vagina can be a possible idea, and but we cannot see any apocrine secretions in this tumor. So again, and PAX8 positivity is not expected finding in skin appendageal tumors. Moreover, in differential diagnosis, urothelial carcinoma is a possibility with GATA3 positivity, but we would not expect to see such low cuboidal papillary, so morphology is not consistent with papillary urothelial carcinoma. Again, a clear cell carcinoma is also important in differential diagnosis. It forms hyalinized papillae. Hyalinized papillae morphology is very important for clear cell carcinoma, but in these papillae are not clear. They're very, very bland, and they have no atypia. We can't see any nucleolized or hobnail-like appearance. Again, is Amaker and Nepsine is negative for clear cell carcinoma. Mullerian papilloma could be accurate differential diagnosis, but the clinical, it is not expected to present in postmenopausal bleeding. It is typically seen in children, so we don't expect the childhood age. We don't expect to see in this age. So consequently, based on this morphologic appearance and clinical information available, the diagnosis is rendered as mesonephric carcinoma by an expert consultant faculty. And a few days later, the patient undergoes vaginectomy and total abdominal hysterectomy by lateral salpingio-oophorectomy. And macroscopic examination revealed that the uterus measured like 3 and 3 centimeter and 70 grams. There was no abnormalities observed. The cervix appeared normal and it was sampled entirely. The vaginectomy was like 1.5 centimeters diameter, and it was entirely compromised of tumor. So I will show you the vaginectomy specimens, the slides of vaginectomy specimen. So this is the surrounding adipose tissue over there, and this is a papillary lesion. And this papillary lesion not seemed hierarchical because it's important for serous tumors. You can appreciate again low cuboidal lined epithelium, and you can again appreciate this tubules contains colloid-like structures. What else we have? We can see some fibrovascular stroma over there in between the papillary areas. Again, it sometimes forms like glomeruli-like appearance over there. This sort of glomeruli-like, or sometimes micropapillary-like. These tubules and papillary architecture and some sort of glomeruli-like appearance in the samples. So this appearance is very, very specific for mesonephric proliferation, mesonephric carcinomas. The microscopic findings I described are quite typical for mesonephric carcinoma, and in this patient we were only able to demonstrate GATA3 positivity. We did not observe findings expected in mesonephric carcinoma, such as CD10 luminal positivity, TTF1 positivity. The negative morphologic findings, along with the patient's normal cervix, support our diagnosis of vaginal adenocarcinoma, HPV independent mesonephric carcinoma of the vagina So hope you enjoy the case. Have a great day. Bye.